Yes. 736-1090. Can you hear me now? Hopefully. Apparently I'm dating myself. Okay. Proceed. Okay. Oh, no. How long is this away? There we go. Okay, so these are objectives that were emailed out to the district. Um, we're going to talk a little bit about anatomy, the restrictive and obstructive pulmonary disease and the difference, um, benefits of exercise, precautions when working with people who have pulmonary disease, different methods of exercise testing, and understand those benefits and risks, and also how to use exercise tests to prescribe safe and effective exercise for people with pulmonary. So, real quick review. Has the two lobes, left and right. The left has, there are two lobes on the left and three on the right. There's the trachea coming down, branching into the two main bronchi, then you have the secondary bronchi, tertiary bronchi. So you get the, is there an audio component to the lecture? Okay, yes, there is an concentrate. That really can make a difference. Okay, they probably have to unmute it. Right, you talk that or talk back to it. Okay. That one. So what's your presentation without that though? That's true. We'll see. Okay. All right. So, and then at the end of the tree is the alveoli. And when we get to the obstructive component or obstructive diseases, that's where. Oh, hey, it's more. That's enough. Makes sense for the day. So for the alveoli at the end, which are one of the main components when we're talking about obstructive diseases. And then the diaphragm is the bottom of the main respiratory muscle. And then there would be accessory muscles, which we talked about over here. The sternocleidomastoid, the scalenes, pectoral, internal and external intercostals, also the abdominals, and quadratus lumbar. Quiet breathing is mainly passive using the she left. All right. Is that good? Awesome. Okay, she came back. It's not the fin cage, it's the rib cage. The elasticity of those help to expire, expiration, technique of expiration. Principal inspiratory muscles of the diaphragm and the external intercondral part of the internal intercostal. And we'll get into that when we talk about the breathing mechanisms that people use when they have pulmonary. So ventilatory mechanics, chest expansion of the bucket handle, motion of the ribs, and you also have the pump handle, bucket handle. If you think about that, you've got the handle here attaches at two places on a bucket. That's from the side of the lifting motion with the bucket handle. The pump handle is like an old-fashioned well that attaches at one spot on the out, and it moves almost like open chain. Yeah. Those open up the rib cage with the muscles helping to open up the ribs for the negative pressure to help pass that into lungs. Exhalation, again, quiet breathing, the elasticity of the lung tissue and of the muscles resting and rib cage expires the airway muscles. Active exhalation uses the external intercostals as well as the abdominal muscles, even those actively to push air out. So, obstructive disease. Really one of the most common of the pulmonary diseases, also known as COPD, is disruption of the elastic lung tissue. Several different examples: asthma, chronic bronchitis, emphysema, and cystic fibrosis considered an obstructive disease. Asthma, people are most is one of the more common ones, especially in young children. It's smooth muscle contraction in the bronchial walls. There is supposed to be some contraction there. That's an overcontraction of that smooth muscle, closing down the airways so air can't get out of the lungs. You get a hyperinflation. Also, you see this thing called dynamic hyperinflation if it's done during activity. The air gets trapped in the lungs and it creates that feeling of shortness of breath or dyspnea. So, in order to help that, there's certain exercises we can do, certain breathing techniques to try to help that try and get more air out of the lungs. Emphysema as well. That's more of a destruction of the alveoli that are at the ends of that bronchial tree. So, with hundreds of millions of alveoli in our lungs. And each of those little alveoli are a lung. And they have capillaries in them and bring blood from the heart to the lungs back to the heart to come to the body. And the lungs, they absorb the oxygen that we just respired into our lungs. And they're very elastic, and when you exhale, the pressure pushes those alveoli free from that. Now, when you breathe in, it opens up, and it continues to do that. I think of those as bunches of grapes. So you got a big bunch of grapes, the air comes down the vine, into the grapes, opens up. When we have emphysema, it's a destruction of the alveoli. And it actually I think of it as it becoming bigger. You have less surface area because you have a bigger grape. And the surface area becomes less, so you have not only less surface area for the air to, the oxygen to get to the blood and the carbon dioxide to get out of the blood into the alveolar space, you also have less elasticity to the remaining alveoli, and there's not enough contraction to get the alveoli, the air out of the lungs. Restrictive disease is a decreased lung compliance. So this isn't a hyperinflation and of the alveoli. This is actually almost a tightening of the lung tissue, where the lung tissue does not expand, is not allowed into the lungs. So decreased elasticity of the lung tissue. Also, musculoskeletal changes can cause a restrictive component to disease, such as thoracic kyphosis or scoliosis. A severe one won't hamper that side of the lungs because the ribs or the spine are closing down on that side, so they can't open up the air to the lung tissue. Interstitial lung disease, pneumonia, and pulmonary obstruction. Those are, I think, ILD is one of the more common restrictive diseases. It is sarcoidosis is involved. It's included in that sound quality of muscle. For sound, that's true. Pulmonary fibrosis, radiation fibrosis, sarcoidosis, asbestosis, all comes down to one tissue, not allowing the one tissue to expand. I can't hear it. I don't know what to do with that. don't know what else I can talk about. Full circle. Technical difficulty. Please come back. Yes, I think it is closer to or not. So. Okay, so exercising the pulmonary. A lot of the literature talks about pulmonary rehabilitation. One of the requirements of rehabilitation, pulmonary rehabilitation, is to prescribe exercise as well as education components. So educational components, education on medication, education on breathing techniques, education on exercise, energy conservation techniques, all of the above. So, but a lot of times, pulmonary rehabilitation studies include exercise. So you can do a web search on exercise for people with COPD or restrictive disease or cystic fibrosis, and you'll just get studies that have you'll have studies that have exercise specific as a treatment, but a lot of them you can also use pulmonary rehabilitation, and a lot of that will exercise as well. So a lot of it has to do with reading the studies, see how much focus was on exercise versus most of it will certainly exercise. And that exercise also has to include aerobic exercise and resistance training. So in the past 10 months, starting October of this year, there was a systematic review published by Cochrane on field. I think that one was on restrictive disease, and then there's one just in the last 3 months on COPD. The one with COPD included 65 articles, 31 from a prior systematic review back in 2006, and then they picked up 34 more that were included in the systematic review. This is a quote from the abstract. It is our opinion that additional RCTs comparing pulmonary rehabilitation and conventional care in COPD are not warranted because the evidence is so positive for the people with COPD that, okay, we got it, it's good. It helps. But we need to see what components are actually helping. Is it the exercise? Is it the education? Is it the medication? What's making the difference? That's what I've driven research for COPD and pulmonary rehabilitation should be focused. I'm a little biased. I like to especially the exercise that's helping, but I guess I'm biased. We see improvements in health-related quality of life scores, aerobic endurance strength, and in some you can see some oxygen uptake changes. That would be VO2 peak instead of VO2 max, if anyone's familiar with those terms. In pulmonary rehabilitation or anything to do with pulmonary disease, if we're doing exercise testing, we try to use the term peak oxygen uptake as opposed to maximal oxygen uptake. Most people, because of their disease, can't achieve their maximum oxygen uptake because there's some downward-flow limitation there. So we'll use the term peak oxygen. For interstitial lung disease, not so much. There were 9 ICUs during the literature. Only 5 criteria for inclusion. So there's 5 versus 65. So there's a long way to go in studying restrictive disease. I think a lot of it, there's a lot less people that have restrictive disease versus excessive disease. A lot of it's where the money is. There's a lot of money in COPD research. I think a lot of it has to do with preventable conditions. With the exception of SU, obviously, but smoking is certainly a main factor that causes COPD. So I think that's why there's a lot more focus on obstructive disease. It believes that pulmonary rehabilitation is beneficial. However, they stop short of saying that it is beneficial, that highly recommended because the 5 studies that they did use were low to moderate quality. They weren't very good. Didn't provide very good numbers, and they were small numbers to begin with. They did state that it was safe, that there were no harm into the patients with restricted disease or pulmonary rehabilitation, and that they just needed to see more research on that. But a lot of what I've seen in the literature regarding exercise and pulmonary rehab show that there is improvement in strength and endurance. So precautions, things to watch out for when you're working with people with COPD. And this is something not just if you're doing pulmonary rehabilitation, but if you've got someone coming in for knee pain or back pain or any orthopedic condition, these are things to really watch out for. There's a lot of people out there that have COPD. And this is not it's not anything to be scared of. I think a lot of people hear pulmonary disease, hear cardiac disease, lung cancer, and I think people get a little scared because it's something that they learned about in school, and well, I'm not going to work with that, so I'm not going to worry too much about it. And there's someone that comes in with COPD and goes, oh my God, what am I doing? It's not that scary. I think it's pretty straightforward in what you need to watch out for at minimum. Keep the oxygen above 90%. The oxygen saturation should stay above 90% at rest and during activity. This is hypoxemia if it drops below that. The patient may need supplemental oxygen. And this is something that if they need it, the doctor has prescribed. However, this is something that we can monitor with a very inexpensive equipment. You can buy finger pulse oximeters for $50. I think we got some for our clients at $45. It's inexpensive. I think it's something that every client should at least have in a drawer in their office somewhere for those people when they come in for therapy. Something that should be watched probably depending on what you're working with them on. Oxygen saturation should be monitored throughout the fitness session, especially if you're on a treadmill, if you're on a stationary bike. We have equipment in our it's called a gear staff. Essentially to reach this humping order track, seated arms and legs alternating back and forth. Arm bike. These are things that we should. I have not seen a difference. What I try to do is make sure I'm watching using this. Shoot, I have another recorder. I'm trying to make sure I use the same finger to make sure that I'm getting a consistent reading. It's going to be plus or minus 2% of most of the standard errors for the pulse oximeter. Even the small ones, the cheap ones are about 2%. Big ones are about. So you're going to watch that's something to watch. We had a run there for about a 2 years and a month ago. People coming in with pretty poor perfusion in their fingers. So we were having difficulty getting accurate oximeter readings. They do sell forehead sensors, earlobe sensors. Those weren't pretty expensive because then we would get one of the large oximeters that has interchangeable sensors. We were hoping to get one of those for our clinic because it certainly would help. I think it would work for people that are on the treadmill, if it's on the forehead or the earlobe. You're not getting any side effects from them walking, so if they're have their hands on the side of the treadmill or anything, getting it after their forehead or earlobe. For some reason, the guys on the National didn't really want to sell us anything. It was really difficult to get some information out of them. But those would be the best case scenario. If you have the expendable income to purchase one of those, that would be the best. But again, that's for most clinics, I think the $45 time works just fine. Yep. Yeah. Yep. Yep. Some of the ones we have actually have a little waveform, a little sideways. If you're getting a nice even sideways, that's a good one too. But then you have people that have an irregular heartbeat. That makes it a little bit of a challenge too. So there's a lot of different when you're looking at the pulse ox number. But I think it's going towards that too, of trying to get better for. Go for it. Okay. I'll restate that for the people on the internet world. That the number on a pulse oximeter is the percentage of oxygen that is attaching to hemoglobin. Percentage of hemoglobin that has oxygen in it. If you have low hemoglobin numbers, they saturate at 100%, but you're still going to be low on oxygen because you're only saturating the amount of hemoglobin that's there. Thank you, Kevin. There's Kevin Neville. Cardiopulmonary treadmill. Yeah. Oh, I missed. There I go back. Okay. Also, you need to consider other comorbidities with your patient. Inadequate nutrition. Are they diabetic? Low blood sugar is kind of a bad thing when it comes to exercise. Also, do they have low bone mineral density? That the osteopenic. A lot of the you get some little old lady that's ectomorphic coming in and also has COPD. You're going to want to be careful about what exercises you prescribe. The stress fracture point of view. Are they hypertensive? Do they have cardiac impairment? That's going to have an effect on what you prescribe for exercise as well. How will you for it? You also need to consider medications and their effects on exercise and vital signs. The people I look out for that is very common are beta blockers. Most common ones I see in the clinic are cardiac selective beta blockers like metoprolol, atenolol, bisoprolol. Those are the three most common ones I see. There's also beta blockers that are non-selective. However, those can cause bronchoconstriction. So if someone that has COPD or any kind of pulmonary disease probably may not be prescribed other type of beta blockers. And health beta blockers are the engine OL. There's two calcium channel blockers, diltiazem and verapamil. Those will also chemically decrease the heart rate. These are all for people who have hypertension. By the way, I don't think I put it on there. So they have hypertension and they may be prescribed metoprolol or diltiazem or any of those medications for their hypertension for the fast. So when you're exercising someone aerobically, like treadmill, stationary bike, their heart rate won't increase at the same rate as someone that's not on a beta blocker. Also, you need to look out for if anyone's on gasoline or caffeine or any beta-2 agonist. Specifically, albuterol is a big one to look out for because most rescue inhalers are albuterol. So those will artificially increase the heart rate. So it's something to watch out for as well, especially if you're trying to look at it. Okay. So with exercise, you really should not be monitoring the oxygen saturation. MD will often allow titration of oxygen to maintain O2 greater than 90%. However, you want to check with them first if they have not written it on the description. For those folks, heart rate should be monitored throughout the session again for safety, and I usually target heart rate. Also keep in mind that if there are any other influences, drug influence on their heart rate, stress, pain, those kind of things will hit heart rate. Blood pressure should be monitored throughout the treatment session. We try to watch for 200 over 100 as a stopping point for any exercise. Actual drug haven't done any recommendations that makes a difference. Okay. Yeah. Oh, okay. Okay. No, sure. Right. So again, out there in internet land, if you still can hear me, Brett, have a note stated 200 over 100 is a good resting, a good stop for resting. If the resting blood pressure is at that point either 200 or 100, then that is a contraindication for exercise. It depends on how much their blood pressure increases during exercise. If they started high, they're certainly going to go up higher, but it should not depend that they're okay. I would therefore assume that if they started low but ended up going spiking, then that would be a problem. Also, diastolic shouldn't change too much during exercise. So this is what patients think when they come to me. You're going to do what? I can't do that. Get that a lot because most of them come in, the physicians tell them, we're going to get you the pulmonary rehab, and then let's just start pulmonary unit. Okay, we come in and, well, what's pulmonary rehab? So I spend half my session explaining to them what pulmonary rehab is and what exercise. And I think even if they're in an orthopedic class, for whatever pain they're seeing, and, well, I can't exercise, I get sure the doctor just wants the best. They think exercise, they think all this stuff. And we know that it's not necessarily. Again, equipment for safety in the clinic, oximeters, 6-arm manometer, and a rescue oxygen would be best if a lot of people that have sort of pulmonary disease. And treatment is your typical exercise equipment in the clinic. If you are focusing on pulmonary disease, we have a manometer to measure pressures, and an inspiratory muscle trainer. We'll talk a little bit about that later. That's the equipment that we have in our clinic to work with. One of the first exercises I tell them to do is from the go home and breathe. Allow them to go practice. If they aren't familiar with first lip breathing, I teach them how to first lip breathe. The evidence for positive benefits, however, it's low to moderate quality. And not everyone will feel okay with fluid test. What some articles have found is that if people taken on first lip breathing on their own and figured it out, it works best for them. If people have to be taught how to do it sometimes, for those people, it tends not to work best. More information is needed to determine whether it's what population it's effective for. Also, the latest evidence is saying they're not sure if it's actually going to be helpful during exercise itself. I still teach my patients to do that during exercise because the majority of people, it helps slow down their breathing. They don't hyperventilate as much. It helps them to get that air out. Helps them to clear up the airways to get air back. Those with moderate to severe COPD for the gold standard, and I think yeah, there's actually a gold committee on COPD. And moderate COPD is an FEV1 less than 80%, and severe is less than 50%. I believe it was 50 and 30. 50 and 30. 50% is moderate, 30 is severe. That's FEV1, and that's done by pulmonary function tests, typically a hospital or outpatient clinic. So again, evidence leads to positive side effects for people with COPD, so I want to teach them how to do that when they don't have it. Typically, you're going to breathe in over the count of 2, breathe out over the count of 1. As you're breathing out, you're unfamiliar, so we're not all going to practice. Breathe out, actually pressing your lips together like you're trying to blow out your skin. You're going to slow that breathing down. And you want to use your abdomen to help push the air out. So breathe in through your nose, and then out through your mouth. And out through your nose. Really tighten your abdominals to push the air out, but you should also be creating a pressure with your lips that you're blowing against. Help slow that breathing down and help you to expel more air. Pushing against resistance, which is creating more pressure to get air out of your lungs. And that's the point. Now, it's trapping air. There's dynamic hyperinflation. It's just overinflated lungs. They can't get more air in, so we're trying to help them get more air out to catch the breath. Diaphragmatic breathing, same thing. This is trying to retrain on how to use the diaphragm. Get that working instead of sensory muscles here. Purify the mastoid scaling, the rib cage musculature, moderate quality evidence at best, but this seems to have more disagreement whether it works or not. I also try to work with relaxation techniques, stress control, panic control, mental imagery. Seems to work quite well with these people. When I was a teenager, I took life writing classes and swimming lessons and all those good things. They teach you when you're taking those life writing classes that people who are having trouble in the water, they're going to panic. So that's how I think of this population. They're having trouble catching their breath. They can't do anything without getting short of breath. I think about that, and the people that are drowning, they're panicking. They can't catch their breath. They can't stay above water. And so those people are going to high stress, high panic. And so helping them calm down, trusting that with that, creating that mental imagery of being in a calm place, peaceful place, whether that's a field for wildflowers or the beach or Disney World. Whatever's calm for you, that works. And so we talk about that, and I have them go home and practice that mental imagery along with those breathing techniques. Because when they actually need to use that, it's not the first time to practice. It's practicing when they're home, when they're calm, when they're relaxed, in a safe environment, have them sit down. In case they do it too much, they get lightheaded. And what that happens at the countertop is that kind of a hard thing to fix. So I want to sit down, nice and relaxed, practice these calming techniques to help them with their anxiety. This is one of many focuses of research of how to deal with people that have COPD, anxiety, depression, factors, because it does play a factor in their shortness of breath. There was this, I forget the journal, but it was a psychology journal that studied COPD. They said those that have high anxiety may report increased symptoms, but they don't necessarily have worse function. But those with worse function and increased symptoms tend to present with higher anxiety person. So it seems to go along with worse symptoms. Consistent with higher symptoms. Exercise testing. So one of the things in cystic fibrosis that is taking off is trying to get more feedback to cardiopulmonary exercise testing. Although this is excellent in theory, in practice, and in clinical, it's really tough to get done because it can be an expensive test. There's a lot involved with it. It's basically a stress test. It's a test that back when Lance Armstrong was big and before it came out that he had steroids, you often saw pictures of him have the mask on and pedaling. That's what it's trying to find out exercise test. Routine monitoring and assessment of exercise-related typically it includes gas exchange for the loss of oxygen, carbon dioxide, and imaging of their lungs. Helps with physical activity counseling and recommendations and exercise. It gives you a picture of the entire system, the metabolic system, the respiratory system that includes gas exchange, dyspnea and exertion, and also the functional capacity of the cardiac system. It also helps to determine this and establish precise prescription for therapy. You can figure out the safe limits of activity, assess the effectiveness of therapy because they would perform better on a follow-up detox, and they also improve the patient. They also be able to see how it improves the patient's function. So a CPAC is getting on the bike, and it's basically a graded exercise test. You can do it on a treadmill as well. I think most people are familiar with doing a stress test for cardiac assessment. So every 2 to 3 minutes, the resistance increases, or the grade of the treadmill increases to make it harder to put more stress on the system. The computer is calibrated and the gas exchange is analyzed, carbon dioxide out, oxygen in, and through lots of calculations and numbers that we're not going to discuss here because we could be here all night talking about that. You can see what their peak VO2 is, their peak oxygen uptake, which then you can as their peak oxygen uptake, see what their heart rate is, and from there you can use formulas to come up with a target heart rate for that particular person. This is to increase aerobic capacity. Then there's submaximal testing, which we're more familiar with in the clinic, 6-minute walk test, the shuttle walk test, and a graded exercise test. So 6-minute walk test, I think anyone not familiar with a 6-minute walk? Not only oxygen, what happens during ambulation, what is your heart rate response and recovery to this test, the blood pressure response and recovery, you get a distance of average speed from that. Modified shuttle walk, any people familiar with that test? Okay, so you have a 10-meter course. Tones, extra tones are 9 meters apart, and the goal for the patient is to walk with a pacer. There's actually apps out there that you can use. It's called the Bleep test. So you can Google Play search that, or you can App Store search that. It's called the Bleep test. For the first minute, you have to walk 5 times from around the cone. So they'll start to one length, essentially 20 seconds, and they'll do the second length, essentially 20 seconds, and the third length, essentially 20 seconds. The goal is to continually walk every minute. The goal is to walk continuously. Every minute, the speed increases. And it continues to increase every minute. And the stopping point is exhaustion. We figured out that by the end, the person would be jogging 5.5 miles per hour to hit each marker at each speed. The beats are that fast. So this is another widely accepted sub-max test. I found it difficult to do because the patient had difficulty understanding that they were not to walk to the far end as quick as they can and walk to the next end as quick as they can. And so they exhaust themselves before they get the second, third shuttle. But then talking at one of the conferences last year, I guess now you're able to, you can walk them for the first 3 uh, minutes to help pace them during the shuttle walk time. So, it's nice because it's only 10 meters. It's a short distance. Whereas, really, if you look at the 6-minute walk test and you do it the way it's supposed to be, it's 100 feet. That's kind of one distance to have an FTP clinic uninstructed with down off walking through. So it's actually just test new, and you just need the pre-recorded beats to tell the person when they should be at each call. I mentor at the Boston Children's. They developed a graded exercise test. There's no evidence on this, but this is what they were using. Basically, again, it's a stress test on the treadmill. And the goal is to increase the nut level every 3 minutes. So you increase the speed of inside of the treadmill station, basically starting at 2.5 minutes and increasing 1 net every 3 minutes. We're watching their oxygen saturation, their heart rate, and you use age predicted maximal heart rate as a stopping point, or really can't go any further. That's the other stop. You're taking oxygen saturation, heart rate, blood pressure every 3 minutes, asking them their perceived exertion, using the Borg scale and the distance scale. So using exercise targeting this formula, this was what we tried to do when you get a patient who's had one of the target pulmonary exercise tests. You get the target heart rate, and you're going to subtract the max heart rate from the rest of it. That gives you their zone of exercise, or how hard they exercise. Percent intensity, then you add back in the rest of the heart rate. So for cystic fibrosis, we want people to work 60 to 85%. The College of Sports Medicine, American College of Sports Medicine, they said anywhere from 40% to 80%. They give a huge window for people who have pulmonary disease, which I think that's quite a huge window to provide a target range. And anywhere between those should be fine. Well, that's a big window. So I like at 60 to 80% is pretty good. Depends how much they do, too. And with VO2 peaks, the number you get from that, the peak oxygen uptake, you can also use that to determine that level of energy. So your target there would be 50 to 70%. Other techniques you could use for strengthening, when someone saturates during any sort of exercise, their oxygen drops below 90%, and you just can't keep it in the 90s. Interval training is a viable option. There is evidence out there that interval training is just effective. So you want to do 30 seconds to 2 minutes of high intensity exercise, and then followed by the same duration of recovery less than 40, which would be at 40% of their peak heart rate. And if you have done exercise for greater than 30 minutes, you can see an improvement in their peak oxygen uptake. This is good for children. It's not very appropriate because it's play. That's essentially what they're doing. If they want to little kids play soccer, we run, stop, run, stop, run, stop. So that's interval training. You can have them on a bike, have them on treadmills, anything that is where they're working really hard, and then you can drop that speed down, drop that resistance down so that they're resting. As long as their oxygen comes back up, it's okay. It's working. If they stay below that 90%, then you need to rest a little bit more and don't work as hard. The other thing is you can do resistance training as well. So good old-fashioned strength training works as well. Helps to increase their fitness capacity, their exercise. So we had several patients in our clinic who went through a cardiopulmonary exercise test. They're both women with cystic fibrosis. So FEV1 70%, So a mild limitation. Her resting heart rate was 102 beats per minute. Peak heart rate was 169. So the oxygen uptake was 19.4 milliliters per kilogram per minute. So if we use the Salvonis formula, her target heart rate was 142 to 159. If you use metabolic equivalents or METs, you would see that the target would be 2.77 to 3.88. The math is up there. I won't talk about it. The reason this was interesting is I've been working with this person for probably 1.5 months or so. We weren't getting anywhere. She wasn't getting better. I think part of it might have been because she was so healthy. Most of the people I've worked with had been pretty severe. They were moderate to severe COPD, moderate to severe cystic fibrosis, and any sort of activity was helping them stop. She wasn't on supplemental oxygen. She'd actually just stopped working because she just couldn't do it anymore because of her breathing problem. And so she just to rehab. Like I said, we weren't really getting anywhere. We weren't seeing any functional improvement. She was out for a month with an exacerbation but wanted to come back. So we started the requested, and the physicians referred her for a cardiopulmonary exercise test. And when we used the age-predicted maximum heart rate, and the ATSM guidelines for that was 70 to 90% of their age-predicted maximum heart rate. The lower level of the target heart rate for that was 128 to 164. So we would get her to about 130, and she was working hard. She gave us a board scale of 13 to 14, which is what is recommended. We kept her at that heart rate. So when she came back, we found that we weren't exercising her hard. We weren't pushing her hard. So we pushed her hard. And boy, was she sore after that first session. She was hurt. She was really pushing. She was out of breath. She was saying, if we watched her oxygen and her heart rate, made sure her heart rate was right, and her oxygen was about 90%. But that made a huge difference. Within 2 months, we were seeing significant improvement in her 6-minute walk test. We were seeing improvement in her daily activity. She was able to do more. She was just starting to be able to walk up and down stairs and carrying her load of laundry. Those were the big things that were her goals. Actually looked her up the other day to look at her how her FEV1s were doing and what she was doing. She had been referred back, which is usually a good thing. And her FEV1s are actually in the 90s. So over a long period of time, I haven't been able to check with the clinic. I don't know if she's on a study drug or not. There's some really good effective drugs coming out for cystic fibrosis, so she might be on the study for that. That may be why her FEV1 is so high. I hope that part of it's exercise, but I don't know. But anyway, she's doing well, and I haven't seen her back. So that's a good thing. It's a pulmonary. The next woman we saw was a 22-year-old female, FEV1 of 41%. Moderate to severe pulmonary limitation. Similar resting heart rate, pretty high. Fluid CS seemed to run pretty high. Peak heart rate during the exercise test was 61. You see the mass. Heart rate is 131 to 162. The max, her target max were 4.15 to 5.81. And so I chose her to discuss because we really don't have very many people that want to use CPAPs. And I don't know if any of my patients with COPD right now. But this was interesting because she started coming to us after she graduated college. Kind of through the CPAP, we had all these big grand plans to get her exercising, get her feeling better before she went out and big working. The next week she got a job in Boston. But she came in and we discussed all the different options she had because she was a runner. She was a dancer, ice skater, jazz dancer, you name it, she did it. She was active person and wanted to continue, but she didn't know if it was safe. A lot of people, they cough. They cough all the time. That's bad. That they just have a difficult time doing it. So what we did is I used the METS equation, using 50 to 70% of repeat METS. And then if you Google compendium of physical activity, find all these different activities, and see what those activities are on, you find out the average METS that are expended during that activity. So we sat in front of the computer probably for 20 minutes or so, looking up the different activities that she liked and what was safe for her with her medical situation as it is. And she's actually pretty excited that jazz dance was in it, ice skating was in it, all of her activities were in it. Jogging for consistent time, that was iffy, depending on her speed. But the activities that she liked were in there. So that was good for her so that she would actually maintain these productivity level. So those two were two different situations with two different lung capacities, but where the CPAP was advantageous for us to have them. Exercise prescription, if you look at the APSM guidelines, it's measuring one repetition maximum. You can do 1 to 2 sets of 8 to 12 reps, 60 to 80% of that 1 RM. The important part is patients must have good form, full range of motion, proper breathing, leading to muscular fatigue. That's what the guidelines say. But, as I discussed earlier, you have people that have many comorbidities. People with cystic fibrosis, they can have low bone mineral density as young as 18 to 20. So, got to be careful of stress fractures. And if you're having a patient on the leg press and they have low bone mineral density, it's not the safest to do a 1 RM. So, this is an alternate way to determine leg strength intensity using the boards. You want to choose a resistance that you think will result in the patient experiencing muscle fatigue at about 10 reps. I haven't figured out how to figure that out yet. But I'm working on it. After one to 2 reps, ask the patient to stop and rate the difficulty on the boards. So I'm using the board scale that's 6 to 20, the traditional board scale. I know a lot of people use the modified to 0 to 10. I started doing the board scale when I did my case report. I wanted to use the traditional board 6 to 20, so I still use it. So 13 to 15, I think that equates to 6 to 7 on the modified board. If you're between 13 to 15 on that board scale, that's a size of right resistance to achieve fatigue in about 10 reps. Still want to achieve fatigue in 8 to 12 reps. That's the goal. That's the goal table. Get back to that. You're creating those muscle tears and neuromuscular reagitation to increase their strength. Preferably 15, 20, 25. Not real effective. You're not going to create as good a muscle strength as you want. So you really do want to push them, want to challenge them. So I think using this muscle is a good way to get started, but if you're not going to cause it, that would be the last one. And so it's fatigue. That's why I think that's a big part of knowing when is an appropriate time to stop. If their speed increases, those people at the gym get on the machines and are just going faster and faster and faster. They're doing themselves good. Slow, controlled, 1 to 1.5 seconds out, 1 to 1.5 seconds back. Keep that controlled movement. If they start to speed up, they're getting fatigued. That's the stoppage. Or deteriorate. So one of the favorite ones is the bench press. That back starts to arch. They're trying to pull on the muscle weight. That's the key. They're super. That bench press, that good form, not trying to use their back, not trying to use their legs to get that extra rep. Stop them when they hit that fatigue point. As the patients in your clinic for an orthopedic issue, they can't complete the exercise pain-free. Starts out pain-free, but pain progresses as you continue on. That's the fatigue point at that for that particular exercise. One set to fatigue. If you're creating muscle fatigue, if you're getting those micro tears, one set to fatigue is required. A lot of us learn 3 sets to 10. Well, they found that that's not fatigue. So if you're getting to that fatigue, that's fatigue. You're getting your muscle fatigue, pushing them to their limit. I'll do a second set, but usually the person, after they've got to fatigue, they're pretty tired. That's about all they can handle. Especially if there's this population, the population who has COPD and other breathing disorders, they're not used to working this hard. They think, well, I'm short of breath, I better stop. Well, that may not be the case. They may just be short of breath because they had to work a little bit hard. I used the example with my patients about Olympics. Those Olympic runners, they're fatigued, they're tired, they're short of breath, but it doesn't mean that they ever won. So I try to tell them that. Encourage them that it's okay at times to be short of breath when you're exercising, as long as you know what you're feeling, as long as you know what the oxygen saturation is. Oh, that's the 2 goofballs that like to wear their sunglasses in the middle of winter. Absolutely. Like you said earlier, I spend at least half of the first session just talking to the patient, going over their medical history, getting to know them, what they're having trouble with, what do they want to accomplish, and really making sure they understand. Making sure they understand what they're coming into. That they're going to exercise, but we're going to do it safely. We're not going to put them in a situation that they're going to be in trouble, that they're going to have issues. Because just as much as they don't want to have issues, I don't want them to have issues on my watch. So I want them, there's a question here. Any suggestions on working with a nurse? Lung transplant, I think it was. Is that correct? How do I get that back? So let's go back to the... Yes, lung transplant. Is that pre-transplant, post-transplant? Yes. Post, okay. I've been able to work with this population as well. It's essentially the same kinds of things I do pre-transplant. They are motivated, they're feeling good. I would do a very thorough review of their medications to find out what they're doing, what medications are they? Are there any side effects? Most physicians are going to refer them to pulmonary rehabilitation. Their contraindications are going to be similar to post-bypass, so they're going to have sterile precautions. So be very wary of any upper extremity exercise, stretching, especially I believe those are 8 to 10 weeks after the transplant. Monitoring their oxygen and heart rate is going to be important. Getting them back on the treadmill and working them back up to working their endurance back up. That's going to be huge for them. They want to get back to moving just as much as anyone else. And they're some of the most motivated people I've worked with. But I would say, just like you've been doing, pre-transplant, work with them post-transplant. Don't be afraid to push them. Also, I would watch out for precautions and where you're working with them. Do they need the mask on? Make sure they're aware. If they're not sure, contact the surgeon. I would make sure we try to clean our equipment before and after each patient using tabby wipes. Because you just don't want them to get sick, and especially those first 3 months after, that's when they're I think making sure you have good medical review and making sure everything. Okay. Okay. There's a question regarding bronchiolitis, bronchial obliterated obstructive pneumonia. Okay. Okay. Right. CPAP, cardiopulmonary exercise test. Yeah. The exacerbation just may be from an illness. It just be a cold or an allergic. Yeah. So maybe a lot of what I found, again, this is just clinical, this is not very heavy any evidence, but I mean, sure it's in there, but I think I know I was at first a little hesitant to have the patients work front of us. I think he did a little thing, but that's us. You don't want to push them, they have COPD, or they have sarcoidosis, they have asbestosis, the restrictive disease, they can't do much. They're going to get short of breath. Well, yeah, they're going to get short of breath. It's about making sure it's safe. So, in regards to, I don't think I've had maybe one or two. It's not that common. Yeah. So, again, I would say by what we know best, and that's exercise, and just making sure that it's hard enough but safe. Making sure you're watching that oxygen, making sure it's not dropping, and if that's not staying blood. Like, I think that's the key, and I don't know if I expressed that, but making sure that if it drops, then it comes back before you continue. As it continues on, then you want to change your aerobic exercise, treadmill, walking, bicycling, to more of an interval, or just strength training. Giving them TheraBand exercises. They've done studies with TheraBand to show that that's effective. And education. Sorry, the education got interrupted with the little internet people. But I think that's the biggest key. I learned a lot from personal experience with the patients and making sure they understood where we're going. And I think the big key also, this is not like traditional physical therapy. So you go in, a shoulder hurts, here's a hot pack, here's a stretch. Oh, it feels better. It doesn't happen that way. It's going to be 2, 3, 4 weeks before the patient starts to feel. They may like it to start with because, I'm finally doing something. I know that I can do it. I feel better just knowing I can do it. And then I'm not hurting myself. I get a lot of that. But I get a lot of people who say, oh, it's anything. Nothing's changed. Well, it's going to take some time. And this isn't, you don't learn to run a marathon in 2 weeks. You want to do 5K in 2 weeks. It takes time. It takes training. So I think that education is letting them know that you're in it for the long haul. This is 8 to 12 weeks, and they've done studies that say 4 weeks of pulmonary rehab is not enough. You need to have 8 to 12 weeks, at least 2 times a week, if not 3 or more. We do 2 times a week, an hour each time, and that's pretty effective. Well, minimum 2, but there's studies that say 3 to 5 is effective. But making sure they understand that it's going to be a month, it's going to be 2 months, it's going to be 3 months, and then trying to make sure that they have some sort of maintenance program, whether it's going to the Y, a local gym. I had a patient who said, Holly, their high school gym is open to the public 2 or 3 nights a week. That is an option, and that's a cost-free option. And patients love that. So I tell them to check with their schools. It's open. Because if they're using public dollars sometimes, I said sometimes the deals are, okay, we'll open the gym a couple nights a week so that the and I'll encourage them to do that. I want them to continue. I want them to start. I try to say years ago, my friend, I try to do that. Because that's, those are expensive. But finding something for them to do to maintain, because they did a lot of hard work to get themselves to a better position, and for them to just stop because they don't do any follow-up exercise, that's really tough. That's why they don't come back, and they get exacerbation. And I just see people like, oh, so what'd you do now? So things like that are important. The education is so key. I don't know if I missed any questions out there on the internet. Oh, this oops. I knew I told Casey, I told someone I thought I was going to do that. I think it just happened 3 minutes ago. That is pretty good. Anyone have any questions out there? Sorry, I disconnected a little bit. Good. They probably figured it was over. We see them at the hospital. They have pulmonary function lab.